Vice President for Clinical Innovation at St. David's Healthcare System here in Austin. My role, though, tonight is here as the, with honor and responsibility as the chair of the CPRIT Oversight Committee. So first of all, thank you all for being here. And my job tonight is sort of to moderate the panel discussion that we're going to have now about this film and topics related. And we have 4 fantastic panelists tonight with us. And I might just ask the panelists to come on up, and then I'll sort of introduce you as you come forward. We've got Dr. Greg Aune, who I'll just read, is pediatric hematologist, oncologist, assistant professor of pediatrics, University of Texas Health Science Center at San Antonio. One of the people you saw in the film is a national treasure, I would say. I've just met him for the first time tonight, Dr. Emil or J. Freireich. Dr. Freireich, as he's coming up, I'll just mention, you got a glimpse of it in the film. He is known as the father of combination chemotherapy. So before his work, we thought about cancer and treatment as a single agent, see what happens, and then if something fails, you go to the next agent, and sort of like, as you saw in the film, based on the sort of the principles of infectious disease where 2 drugs are better than 1 when treating TB, he was in that group that early on decided that combination chemotherapy should something be tried, and that is a foundational idea in all of cancer therapy today. So again, a treasure. Down from Dr. Freireich is Dr. Margaret Kripke, who I have the great pleasure and honor of working with at CPRIT. She is our Chief Scientific Officer. Dr. Kripke came to CPRIT after a distinguished and long career at MD Anderson, where she was the founding chairman of the Department of Immunology. And for those who follow cancer therapeutics, one of the most exciting areas in cancer therapeutics today is the rapidly emerging immune therapy area. And so, again, the lineage of that work in many ways is in that immunologic field. And Margaret, again, was the founding chairperson of one of the major departments of immunology, cancer immunology in the world, quite frankly. Last, Dr. Debra Patt, hematologist, oncologist, and director of public policy for Texas Oncology. I'll note that what's especially interesting, among many things about Dr. Patt, is that I believe she manages the database which is associated with her practice and her group's practice, which includes, I think, 12% of cancer patients in America. So that's a very important and very vast database and a vast asset that she runs and works on. So welcome again this evening. So this is the panel portion, and what we're going to have is a series of questions, and you all are invited to submit a card, I believe, to Jeffrey Hahn, who's back there, and if you have a question, we have some prepared questions which we'll use to sort of begin and anticipate. And again, there's a bit of a time frame here, so we won't go on for more than 4 hours. No, just kidding. But nonetheless, we'll start with a few questions, and then as we go along, we'll see about time for audience questions as well, and we hope we can do that because that's, you know, we want to be responsive to your thoughts. But what we thought we would do is start off with the question, we're making great strides every day to fight cancer. What do you consider some of the biggest milestones in cancer research history? And we want to start with Dr. Freireich on that one. Some of the biggest milestones in cancer research history. Of course. Yeah, good for sales.
Because it's going back 4,000 years, you know.
Right.
But at the risk of being vain, I think that the first cure of a systemic cancer was a major milestone in cancer research, and it's changed the whole focus from palliation to cure.
When was that first cure? What was the first cure of the cancer?
You saw it.
All right. Anybody else on that?
Plastic leukemia in children.
Right. Dr. Patt?
I think of I think of our progress in cancer in different chunks, and I think we're all biased by our own experience. So Dr. Freireich certainly is biased by when he started his career in oncology. As he said, every parent knew that their child would die of leukemia when they presented, and now to have favorable characteristics, have a 95% survival, it's incredible. So I'm biased by the experience that I see really the time prior to 1960 as surgical cures, and really in the 1960s, radiation and multi-agent chemotherapy evolving as cures. I went to medical school from 95 to 99 and can remember so clearly in 1999 that a colleague of mine, her father died of a complication of CML, chronic myeloid leukemia. Because at the time, while CML is usually caused from the same mutation, the Philadelphia chromosome, there wasn't really effective treatment, and the average 50% of patients usually died in about 5 years. And at that time in 1999, there were experimental trials for a targeted therapy called imatinib mesylate, STI 571, or Gleevec. And that targeted therapy really changed the face of that disease. It changed the 5-year survival from 50% to 95% overnight. And it was a really quick approval by the FDA. I think 51 out of 53 patients that were heavily pretreated had responded. So I see the 2000 is targeted therapy. And now I feel like in the last few years, we're entering into a new phase of targeted therapy and some prevention. We have some prevention vaccines, which are pertinent now. So in addition to that, immunotherapy. So you have the checkpoint inhibitors and the PD-1, PD-L1 inhibitors, which are an incredible new era of therapy. And so I think that we continue to have therapeutic innovation. It can't be too fast, so we need more. And then effective implementation too. But that's sort of, I see it in those chunks.
Thank you, thank you. I'm gonna ask the second question here, and again, I wanna ask the panel to feel free to jump in and whatnot, but second question is, why is cancer so difficult to cure? And I'll start maybe with Margaret on that.
Yeah, one of the major problems is that cancer is not a single disease, and it's many different kinds of diseases, probably each one of which is going to require a different treatment. So not only do we have breast cancer and pancreatic cancer and leukemia, each one of those has subtypes within them that are really quite different. And I think in terms of one of the major milestones in cancer research was the realization that there are subtypes of cancer and that treatment specific to each subtype is what's more effective than treating everything the same. So the reason it's difficult to cure is because there are many types. A second reason is, another characteristic of cancer is that it moves from the primary site. And if it didn't do that, surgeons would cure cancer all the time. And the reason they don't is because the cancer has already spread to distant sites. And the third characteristic of cancer that makes it very difficult to treat is that cancer cells are inherently genetically unstable. And that is why children treated with a single agent develop resistance to the treatment, because the cancer cells change, they mutate, and they develop resistance to a single treatment. And so those three factors really make cancer a huge challenge, much more challenging than any other disease that we have.
Thank you. Anybody else? Just, I think it's, I'll just pepper that with the idea that what I've learned through working with and studying cancer is that, you know, a metastasis like a lung cancer, even multiple sites of lung cancer within the lungs might have a different genomic footprint. So you think you're treating a cancer of the lung, but actually you might be treating 10 different cancers of the lung, so to speak. So I'm just reflecting back on the idea of genetic instability or sort of heterogeneity of the of what you're fighting. Dr. Aune, did you have something there?
Yeah, I was going to add, I think a fundamental problem with curing cancer is actually the toxicity of the medications that we have. So as clinicians, I think, you know, we're limited to what we can give the patient that they will be able to tolerate. And I think that, you know, that's what hopefully is going to come with targeted therapies in the future, is that we won't have to deal with the toxicity as much. Because in reality, the toxicity is a major limiting factor of what we do. You know, something like bone marrow suppression requires repeated transfusions, nausea and vomiting have improved, and we have new medicines, but these still are major barriers to us being able to deliver medications that will eradicate cancer.
Thank you. Yeah, Dr. Freireich.
The most difficult reason we can't cure cancer is because cancer has the exact same genes as the normal cells. So the trick is to discover the distinctive characteristic of the cancer cell as opposed to its normal counterpart. That's why it's so hard. I always repeat the analogy that is stated that how can you get a drug that'll dissolve the left ear and leave the right ear intact? Cancer is a descendant of normal cells. So to find, Dr. Patt mentioned the CML problem where we discovered a single genetic abnormality, the BCR-ABL, which resulted in developing a targeted therapy that cures the disease, essentially, 90% alive at 10 years.
Thank you. So I'm going to move to the third question, and again, it's something we've already just touched on as we said it. The third question reads, what are some of the biggest issues, barriers in treating patients with cancer? And I'm thinking not only cellular of different kinds of cancer, needing better targeted therapies, side effects with long-term survivors. There's a whole spectrum of sort of things in that. Anybody pick that up, Dr. Patt?
So I think there are two basic categories. I mean, while there are many things, in my mind, there are two basic categories. One, that we don't yet know enough. And by that, I mean we continue to require investment in innovation and research. It is a problem that only 3% of patients enroll on clinical trials, and so we can't make meaning out of all of them. Part of my work with informatics is that we really need to learn from all cancer patients. We need to be able to use that data well so we can make meaning and use that to improve care delivery. So we don't yet know enough. So we're making tremendous progress, but it needs to happen faster. And then the second problem, as I see it, is that we do know, we don't implement effectively. And that's more of a policy-related issue, which has to do with how we choose to distribute healthcare, how we choose to raise awareness and heighten education. So, there's been a lot of debate recently in the Texas legislature about the HPV vaccination as an example. The HPV vaccination came out in 2006, and we know that adequate vaccination can help to prevent cervical, oropharyngeal, anal cancers. Yet only a small percentage of Texans vaccinate their children. And that's not just that one issue, but compliance with screening mammography, screening colonoscopy, appropriate vaccination, appropriate implementation of screening, and then distribution of healthcare in general. Lots of Texans don't have access. So I think, in my mind, two things. We don't yet know enough, and that we do know we're not implementing effectively.
Mm-hmm. Anybody else? So I'll just sort of resurface the idea that one of the things that is coming forth more and more is the idea that after treatment, there's a life after it. And so you increase survivalhood, and you have things like new kinds of cardiomyopathies and different kinds of problems that relate to maybe chemotherapy toxicity that you've now survived. Any comments just on that realm? I mean, maybe I've sort of said it, but what are your thoughts there? That's part of this challenge of treating cancer patients.
So I think, in full disclosure, I'm a survivor of Hodgkin's lymphoma, is kind of how I got into oncology. And so I was diagnosed with Hodgkin's disease as a teenager in 1989. And I like the word in the movie that one of the people used to describe cancer treatment, and they used the word punishing. No disrespect to Dr. Freireich, because it's pretty incredible sitting here next to you. And when I read this book, what hit me was that I was really just a generation removed from not even surviving. And so I'm tremendously grateful to being one of the people that was able to survive a life-threatening illness. And I think what's happened to me since is pretty telling about where we are in the field of at least pediatric oncology. if you look at long-term studies of children that have survived cancer, about 75% of them will suffer from some type of late health effect that's related to the treatments they got. More importantly, about a third will develop a life-threatening condition that's related to their treatment that they received. And this kind of impacted me personally about 7 years ago, just as I was beginning my oncology fellowship training. I started to have some severe shortness of breath, and to make a long story short, I ended up having to have open heart surgery to replace my aortic valve, and I had a triple bypass at age 35. And while I have a family history of heart disease, I think I was likely not going to get it that early, but it really impacted my view of oncology. And so to me, I think going forward, our goals are to continue to work on targeted therapy, but really have the goal of offering patients not only a cure, but a really good quality of life. And I think that's our main goal going forward. And to be able to be a part of that because of the work that preceded me, that I benefited from as a patient, and just watching the movie and the stories of the early days of NCI is just incredible to me.
Please, Dr. Freireich.
In 1965, when I moved to Texas, I had a little thing on my nose. And I went to see a world-famous dermatologist named John Knox at Baylor University. And John Knox was the man who discovered the cause of aging of the skin. He proved that ultraviolet light destroyed the elastic in the skin. So he was a world-famous dermatologist. And he used the then treatment for squamous cell cancer of the skin, cryotherapy, and he cured my little cancer. And I was delighted when I came for the follow-up visit. He said, Dr. Freireich, you have to understand a fundamental problem with cancer is that it takes multiple events to cause cancer. No single event will do it. The consequence is that cancer is strongly associated with age. The longer you're exposed, the more likely you are to have something go wrong. And when you have one cancer, you're part of the way. So every patient who is cured of a cancer has an increased likelihood of getting another one. So what we're doing is controlling the disease as it progresses.
Dr. Kripke, did you have a comment?
Actually, that was one of the points I wanted to make, is that one of the issues for cancer survivors is that they have a higher than normal chance of getting yet a second cancer, yes, either because they've been exposed to things in their environment or because of the treatment that they received the first time around. There's one other thing that I think, in having listened to cancer survivors, is that many people really suffer a financial burden from being treated with cancer. I am also a cancer survivor, but I'm fortunate enough to be affluent enough that I can certainly sustain cancer, cancer treatment. But there are a lot of people who lose their jobs because they have cancer and they have to be treated. And when they lose their jobs, they lose their insurance. And so not only is cancer a life-threatening disease, it also can create an enormous financial burden on people. And so I think that's another aspect of cancer survivors that doesn't really get talked about that much, but there are other lifestyle, life factor issues that affect cancer survivors that I think deserve our continuing attention.
Thank you. All right, I'm going to move to the next question, if it's all right. What would make the biggest difference in reducing the burden of cancer? Dr. Kripke, why don't I start with that with you?
Well, that's easy. If we got rid of tobacco, we would get rid of...
I know you were going to say that. Yeah.
We would eliminate 80% of the deaths from lung cancer and 30% of deaths from all cancer. Now that's a headline. That is really a headline statement, because if that were reported at a scientific meeting or a medical meeting that we knew how to cure 30% of all cancers, that would make headlines. Well, we know how to do that, and we're not doing it. So tobacco is the biggest single thing that we could do to reduce the burden of cancer in the population. The other things that we can do to reduce the burden, Debra spoke about vaccinating for HPV, another simple thing that we can do, colonoscopies. Prevention, of course, is what we want to do, because prevention spares you the diagnosis of cancer, it spares you the psychological and financial burdens of having cancer. And so anytime we have an opportunity to prevent cancer, we should do that. The other big impact is early detection, because if we detect cancer early, the chances of cure are much, much greater than waiting until it's spread around the body. So those are my answers.
Thank you. Dr. Freireich, please.
What's often forgotten is that the second leading cause of cancer is ultraviolet light. We've got to protect people from UV. It's the second leading cause of death from cancer, our skin cancers caused by sun exposure. If you've had 3 or 4 sunburns during your early life, you're very likely to get skin cancer. But the one that I am campaigning about that everybody hates me for is that the third leading cause of cancer is
Obesity.
Obesity?
Obesity.
alcohol.
Alcohol.
Oh.
And people refuse to accept that fact because alcohol is even more socially acceptable than tobacco. We couldn't control the tobacco epidemic until people realized that you don't smoke in restaurants, you don't smoke in public, you don't. But when someone comes to your house to say hi, your best friend, the first thing you do is offer him a glass of wine. I'm campaigning at MD Anderson to reduce alcohol consumption in the cancer center. We have a convocation every year where we honor the faculty for their research achievements. It's a wonderful ceremony from 4 to 5 in the evening, and when we get done with the ceremony, we walk out of the auditorium and there are waiters holding glasses of wine. And all the alcoholics, of course, drink the wine. If you're not an alcoholic and trained, you would never drink wine. It's horrible. You only drink it because you want the effect of the alcohol. Well, these guys are scientists and physicians, and they just came out of this thing. They drink 2 glasses of wine. They're now legally drunk. 2 glasses of wine, your blood alcohol level is put you in jail. And they get in their car to go home to have dinner, and they kill someone. Alcohol, as you know, kills 25,000 Americans a year from auto accidents. And it's not the drunks who get killed, it's the innocent people who get killed. And it also causes fires, the leading cause of fire. And it's the third leading cause of cancer, and we just can't face up to the fact that alcohol has to be educated and reduced.
And along that point, we know that obesity also is a preventable cause of cancer. So I think to all of our points, that there are many preventative causes that we can act on in the future. And as we think about that, looking forward, we know that in the future, this is not an easier problem. You look at the cardiologists, my husband's a cardiologist in the room, the cardiologists have been excellent at preventing disease. Their anti-cholesterol medications are wonderful. We will only see more cancer moving forward. So, as we look to the future, and we know the age distribution of the population will change as the baby boomers age, and you can look at these census projections, for 2012, 2035, 2060. We know that in 15 years, the area of patients of 60 and above will double. We expect the cancer population will double in that time period. And so it raises a lot of questions about how we optimally implement prevention. how we appropriately treat and innovate this cancer population, and and how we optimally support those patients that survive. And to your point, Dr. Kripke, how you pay for this, because while we've had remarkable innovation, I mean, I can tell you, I have a patient with renal cell carcinoma, metastatic disease for 3 years on 1 pill a day. He's a hypermiler. He runs 100 miles at a time. Now, this is Austin, so we're kind of fitter than average for Texas. But it's amazing. But the pill that he's on is a really expensive one. So our future, we have a lot still to figure out. We need you around, Dr. Freireich, for a long time.
Yes.
You can't retire just yet.
Yes. I'm going to move on to the last of our prepared questions, and then Jeffrey's going to tell us if we have time for some audience questions. I think we do, but and we've kind of begun to ask or to respond to this. Looking 20 to 30 years ahead, what challenges and issues will cancer pose to society? So certainly one of them is the increasing burden of the demographic, and I mean, do you think cancer, I mean, the demographic is there. Will we have less cancer even though we'll have more older people? Or, what are the challenges besides paying for it?
We'll clearly have more cancer because we will have more older individuals. But in addition to that, I mean, we're doing a better job. We actually are making cancer often a chronic disease. So patients require support of a chronic disease and, can remain in remission or have their disease controlled for a longer period of time, which is wonderful, and sometimes often cured, but often a chronic disease. And so that's a longer treatment for survivors. So it brings up tremendous survivorship issues that, we've only just begun to address. And tremendous cost-related issues. We already spend 18% of our gross domestic product on healthcare. Cancer is a large percentage of that spend and will only go up. So I think a lot of issues with how we decide to care for our population and how we can allocate resources to do that and support those individuals optimally.
Yes. Margaret?
Well, I'm hoping that we will have some more of the targeted therapies, which have the promise of being much less toxic to normal tissues and very effective against cancer. As is pointed out in the book, The Emperor of All Maladies, that's not within our reach today, but hopefully that will improve. But I think that many of the problems that we see today will still be with us. We will still need better types of early detection. That really is a key issue, and we have made great strides in terms of colonoscopy, for example. That is really a preventive procedure that prevents people from getting colon cancer. We need many more of those. We need those for all types of cancer. So I think the challenges of 20 to 30 years from now will be similar. I think the cost of health care, the cost of the medications, as you say, are going to be a deterrent, which means access to care will be uneven and not well distributed. So I think many of the problems that we are seeing today will still be with us in 20 years.
Do you all, when you think about prevention or early detection, we have colonoscopy, we have mammography, we have various. Do you think that there's an era of biomarkers that will supplant those more macro things? So again, obviously, a colonoscopy is looking for something like a polyp, which is macroscopic, not microscopic. But obviously, there's other things like biomarkers, which are chemicals in your blood that were, where you'd measure a nano, a few molecules circulating. So, do you think there's another era there, or will we always be in sort of the macro era, or how do you see that?
Well, I certainly hope so, because that would make a huge difference. That would make all the difference in the world to have a blood test or a urine test or some kind of a simple test that would allow you to screen large numbers of people and to really detect cancer early. So I am very hopeful that we will have that. That probably is what made all the difference in cardiology of preventing heart disease, and is the ability to tell when people are on their way to developing heart disease. So we certainly need something like that. We need really a lot more research in that area, because we are not there yet, and it holds huge promise.
I've got several questions. Please, Dr. Freireich, please.
Dr. Patt mentioned the financial burden, and I just want to say one word about that. Many of our targeted therapies now are not curative in the usual sense. The great triumph of the last decade is the control of chronic granulocytic leukemia with a pill, Gleevec. The problem is the patients have to take it for 10 years. And the cost of Gleevec, I don't know what it is today, but it's $10,000 a year.
Yeah.
Dr. Kantarjan at our institution, the head of the leukemia department, has started a campaign to get pharmaceutical industry under control. They've got to reduce the profits that they're making at the cost of these. These are cancer patients, the CML patients, if they stop their Gleevec, they're going to die.
Mm-hmm.
It's like diabetes if you took their insulin away. And you can't charge a diabetic $25,000 a year for insulin. They can't afford it.
Yeah.
And the country can't afford it.
Yes. Thank you. All right, now, you're welcome to clap if you want. I have 5 or 6 questions, and again, I'm going to try to blow through these before 7:25 or 28 or so, and we'll try to conclude at 7:30, I believe, is the time. And then after that, we'll invite all of you downstairs to coffee and dessert. What could be better? And there are people outside as we leave. Is that obesity thing? Why are they laughing? Anyway, so we'll do a few more questions, and then we'll conclude in that way. So here's a question. I'm very interested in research about eating a plant-based, low-oil, fat diet. I've read that cancer rates are lower among those who follow this practice. There aren't many nutrition classes in med school, I hear. So it's a question about, maybe a vegetarian or plant-based or maybe non-so meat-based diet, and is there a value in preventing cancer with that kind of a diet? Anybody? What's the latest thinking on that?
So I would say that it's we know that obesity is a cause of cancer. So eating a diet that will lead you to be lean and having exercise characteristic that will lead you to be lean is probably of primary importance. Things like burnt meat are associated with higher incidence of malignancy. So we know that that's true. Is non-burnt meat associated with increased malignancy? A higher proportion of red meat could be, but it becomes tricky. As I advise patients, and I'm biased, I see about 90% breast cancer patients in my practice, and I do live in Texas and Austin, and we do have a problem with obesity in general, which is a risk factor for recurrence in postmenopausal breast cancer. So what I advise people is sort of the Michael Pollan mantra, eat food, so things that actually look like food, mostly green, and not too much is probably a good general mantra. But I think that people do often want to try to do a particular thing that is more extreme in hopes that it is the thing that will reverse any possibility of cancer. And the truth is that it's not all entirely under our control. Some of it are gifts from our parents. Some of it are exposures that we have no control over. But of the choices that we make, I think maybe 60% of it are useful in our prevention. And I would go more broadly as opposed to a strict vegetarian diet to make healthy choices, eat green, eat food mostly green, not too much, and exercise, be lean.
On a personal basis, any comment on bacon? Sorry, never mind. Lung cancer and pancreatic cancer and liver and ovarian often don't get diagnosed until very late. What is being done for detection of these diseases? Any comments or thoughts on those that are maybe intra-abdominal mostly and therefore maybe tend to be farther progressed before senior detected?
Well, we actually do have screening for lung cancer now. So just Medicare even approved in January CT screening. But to Dr. Kripke's incredibly valid point, the primary cause is tobacco, and if we could alleviate that, we'd be doing so much better. But there is screening for lung cancer. And for patients at high risk, there is screening for ovarian cancer. It just tends not to diagnose until later stages. There's also clinical trials looking at screening for pancreatic cancer in patients at risk.
Yeah, I think these are major areas of research at the moment, and there is some progress being made. So hopefully.
Let me just throw out, here's another one. How important are clinical trials, and why is it that only 5% of adults with cancer enter clinical trials, while it's 80 to 90%, someone says, in children? I don't know that that's true, but what's the deal with adult versus childhood cancer clinical trials?
I'm a pediatric oncologist, so I can comment on the, kind of the angle of treating children. I think nationally we have one cooperative group, and then there's some other big institutions like St. Jude and Dana-Farber that kind of do their own trials. But really, the effort is it's a cooperative throughout the whole country. And so, like when I get a new patient, it's often talking about how research has gotten us from 20% survival in the 50s and 60s to over 85% survival, and talk about how we really believe that research is how we're going to push the bar forward. So it's a standard of care in pediatric oncology, I would say, is actually enrolling on a clinical trial. And so it has to be discussed with the parents and the patients from that standpoint. I think it's different in the adult world just because of the types of diseases they face and just the sheer larger numbers of patients that they see compared to us. In pediatric oncology, thankfully, we only see about 15,000 patients a year for all diagnoses, as compared to, some of the adult diseases which have far more numbers.
So I'd say as adults, and I see patients here at our Austin, at Texas Oncology here in Austin, 3 days a week. We have 60 clinical trials open at our cancer center, so there's not a paucity of availability. But the problem is that the selection really for clinical trials is so specific. So, I saw a new breast cancer patient today that would be a good candidate for a neoadjuvant trial that we had, but she'd had a small cancer 6 years ago, and that excluded her. So you want perfectly clean patients for clinical trials that have had no history of cancer, that don't have comorbid illness. Real patients aren't that patient often. And then, whenever you do have clinical trials and you do have an appropriate patient, it's a lot of time investment on the part of the doctors and the patients to try to get them to that point. And so I think that it has to be a priority for all parties to have optimal enrollment. And even in that scenario, I don't think that you're going to get it close to what you have in pediatrics. Even that said, I'm not so sure I don't think it's 80% in childhood cancer. I think it's less than 40%, yeah. But still it's for certain much higher than on adult trials for the reasons noted.
I want to ask a question that may be a little out of school. It's not one of these questions, but you reminded me of it, and so I'm going to take a chance. It may be politically charged, and so I'll apologize to begin with. There are, I think, in the press, some interest in making cancer drugs that have not yet been proven to be efficacious. There's an effort to have I forget what they call it, but right to try and compassionate use. Compassionate use, and I think there's something maybe before Congress now that may be interested in expanding that significantly. And as a physician, I worry about doing that when you have an ethics out there issue. A, B, you have quality of clinical trials when these patients are, as you said, not really in a good control, and if you've had a previous cancer, maybe you wouldn't, be eligible for a trial because you're trying to get a trial that compares, patients in appropriate ways scientifically. So, any comments on this compassionate use and how that sort of should be looked at in today's environment, Dr. Freireich?
When the AIDS epidemic was killing young homosexual men at the rate of 100% mortality, one of my good friends at the NCI, I'm blacking on his name right now, discovered a drug which could kill the virus. And the government regulators decided that they had to do a randomized clinical trial where half the patients got the drug which had already been shown to be curative, and the other half got conventional treatment, which was 100% fatal. Yeah. Well, of course, the AIDS guys were already politically active. So they marched on Congress. And Congress waived the FDA regulation and allowed them to be treated. That's what we need for cancer. All right. Every day I am being forced to compare a treatment which I know works to conventional treatment, which I know does not work. Secondly, I am repeatedly prevented from treating patients with drugs I know will work because the FDA refuses to approve those drugs in order to protect the bureaucrats' jobs. The states, we began this fight 20 years ago with legislation which is required to reverse the control of clinical research by the federal government. We have become an awful country where there is no freedom to investigate. Patients are not free to choose what they get. Doctors are not free to give what they know is working. We are being regulated out of jail by the federal government, and it's insane. At the present time, there are state legislatures which have passed right to try drugs. We have been fighting in the national legislature to have compassionate use for drugs which we know will work, that the FDA is worried about safety. Patients who are going to die in 30 days should have the right to participate in clinical trials that the federal government has no business in.
There may be some other, I mean, I like that, and I'm not trying to have a political discussion, and Dr. Patt has a comment, I think, but my only quote with thought there is, of course, could there be a slippery slope where some things might be in a gray area of beneficialness, benefit, and you might have some tendency that is unfair or ethically not quite square with patients?
Nobody is opposed to regulation and safety. That's our business.
Okay.
But when a physician and a patient have the knowledge that this is the only thing that can benefit the patient, it's insane.
Yeah. Dr. Patt?
I was just going to say that there are moves to make that better. So How to Survive a Plague, I think, is the name of the movie of ACT UP, which is fantastic. It tells the story of HIV and how ACT UP sort of led to that approval. But it actually did cause major changes in the Food and Drug Administration and how they think about approval and how they think about accelerated approval. And on a national level, Representative McCall, Texas, has a compassionate use bill, really that was born out of a woman here, I think in Austin, Andrea Sloan, who'd had ovarian cancer and wanted access to the biomarin compound, which is a PARP inhibitor we have on clinical trial at our cancer center, but I had nothing to do with that patient. But that sort of was the impetus for trying to approve how the FDA considers accelerated approval. And that's really the take that compassionate use legislation has been, is not really thinking about off-label use as it is accelerating an appropriate approval and regulated process through the FDA. And I'll say that they've made a lot of progress, and it's priority out of Energy and Commerce Cures Project right now. On a state level, we do have right to try legislation that's being considered, and that has changed quite a bit over time. I have to say that in its initial rendition that I'd read 2 months ago, the coverage determination piece is difficult, right? Because some of these drugs are $10,000 a month, and at that point in time, it's changed, but it's tricky because it said that it wouldn't, those treatments wouldn't be covered, and then those patients wouldn't be covered for an additional 6 months. So remember, these are patients that maybe have run out of other options, and so then would they really not have access to hospice care? It's complex. And then would those drug companies be on the hook for the complications? Because they have to report all their complications, and we think drug costs are high now because it costs many $billions to get a drug to market. So I think it's complex. Dr. Freireich's comments I agree with completely, but it's a complex issue that I think at the state level we need to really think about carefully.
Yeah.
And I was going to add from the kind of the pediatric perspective, most of the money that is done for research for pediatric cancer comes from the federal government, and I think we get almost zero from private industry, whereas in the adult world there's a huge amount of funding that comes from drug companies developing compounds. And I think part of from the perspective of the pediatric oncology advocates, the access to drugs for these right to tries movement is there's a lot of worry that should these things move forward, that kids won't have access to these drugs that are being developed for adults, and really trying to change that is a major part of what is happening going forward. And in fact, the bill that you're I think referring to as the 21st Century Cures Act, and some of the advocacy groups are involved in trying to get wording specifically in that bill that will apply to children.
Gotcha. I'm getting the secret sign that says wrap it up, because it's now 7:31. It has been a pleasure to be up here, an honor to be up here with you today. B, thank you so much to the panel for this really interesting discussion about a number of topics that are important. And so can we give them a round of applause? This is a wrap-up moment, so we want to thank also KTLRU, Bill Stotesbury, the CPRIT team, of course, and all who are here. Thank you for being here this evening. And again, downstairs there are refreshments. And for those couple of folks who missed the questions, I think if you stick around afterwards, I bet you'd find a willing responder. So again, thank you again, and we'll see you all next time.